So essentially what we have been doing, probably in 2014, 2015, we did a case of these patients who have severe mitral annular calcium. These are patients who represent very high surgical risk doing traditional surgery. And so what we've kind of developed over time is a technique to use a transcatheter valve, an aortic transcatheter valve in the mitral position. It removes a lot of the risk associated with the pathology, which is that calcium that encompasses the entire mitral valve and can be very dangerous to sew through. Using this technique, we take a catheter valve, put it in the mitral, and we inflate it. We put limited sutures in, and so we think we can reduce the surgical risk of major bleeding, major catastrophic tearing of the heart. We probably reduce stroke risk, and we can get patients through an operation. These are patients that don't have a good option for doing it from a catheter standpoint. So we've kind of developed this technique. I've taught, almost everyone on this manuscript, and we've went around and people have had a lot of these cases. These are patients that no one really wants to treat, but they show up. Some are old, some are younger, some are sick, some are not as sick. The association with MAC is unclear why some people get it and some don't for a lot of patients, but we've never had a great way to treat it. What we're trying now is to use this across a broad spectrum of patients with broad experience now and over 12 centers that we taught and that we've collaborated with. They've helped out, they've used and contributed to the techniques that we've had. So we've had a collaborative group that have helped make this procedure much more universal. So what we describe here in this paper is a 1-year experience. Patients who had undergone this procedure of 126 patients throughout the United States, all undergoing the procedure as we've described it originally, with some slight modifications at certain centers, but by and large, one that's been described in one of our prior papers. Historically, these patients have very poor outcomes at a year, and we've actually noticed over time that these outcomes after these kind of procedures has improved their survival, and our survival in performing this procedure has improved over time as well. So this represents the lowest mortality rate after this procedure from a surgical standpoint that we've ever seen, which is now around 11%. So again, these are very high risk patients, an STS score of 6.8% on average, but we were able to achieve technical success in 94.4% of patients, and all patients had excellent valve performance. Almost all patients had mild or less paravalvular leak. 30-day and 1-year all-cause mortality was 11.9% at 30 days and 26.8% at 1 year, which again is superb. I think one of the important things to remember is that there are a lot of patients who are of an elderly age who will present with valvular abnormalities or heart failure for other reasons. And on investigation, we find that they have mitral annular calcium. And that mitral annular calcium can affect their mitral valve function. So it's important not to ignore the presence of mitral annular calcium with valve disease. We have to make sure that we treat it adequately. Oftentimes it's ignored or not treated because it's too challenging to treat and other lesions are treated. I think it's important for everyone to recognize these pathologies as clinically very important for a patient's long-term outcome. And doing a diagnostic such as an echo down the throat, a TEE, and a CAT scan can help us investigate what therapies are available, as well as the severity of MAC.